a biotin deficient face with a characteristic facial rash along with an unusual facial fat distribution, which has been termed as the biotin deficient face. So concluding, we just aim to highlight that biotin deficiency can even present in the absence of cutaneous manifestations, which were not seen in 2 of our patients. And we just, one of these patients, the biotinidase levels were done just because the child had a refractory seizures which was not responding to any of the anticonvulsants. So we just, variability of presentations, absence of the cutaneous changes, interpretation of the metabolic panel, because that is where usually we get non-specific changes which we are unable to interpret, and also to highlight on the biotin phase. Thank you very much.
The main reason for presenting was because some of them we followed up now for about 8 years or 9 years was the longest for one of the patients now. They're all doing so well, and just wanted to highlight that it's a very easily treatable cause of neonatal seizure.
I agree. Very important to pick this up, because with treatment they can do extremely well, and the treatment is so simple and so cheap. The problem is that if you are slightly delayed in your diagnosis, they are almost certain to be deaf, and if you're more delayed, they'll have a nasty leukoencephalopathy and severe handicap. So very, very important to pick them up promptly. Can I just highlight one slightly unusual feature about the family you primarily presented, and that was the age of onset. In particular, I am just a little skeptical about the very early seizure being due to biotinidase deficiency, because biotinidase is an enzyme for the recycling of biotin when you break down your carboxylases. And so on the whole, you have to run out of biotin before you run into problems with this particular disorder. And so for that reason, it's really very unusual to present before the age of about a month with biotinidase deficiency. And on the whole, if you present with a biotin responsive multiple carboxylase deficiency within the first month, that would be hollow carboxylase synthetase deficiency. Now, you appeared to have the diagnosis confirmed with the enzyme test, but in most cases of biotinidase deficiency, you get undetectable biotinidase. You do get some reports of partial biotinidase deficiency, primarily picked up by screening, but how much clinical problems those partial cases result in, I doubt. And you might certainly not expect a partial deficiency to be giving you such a very severe early onset of seizures. So it is a little bit unusual, and it is just possible that this patient actually was a carrier for biotinidase deficiency or something like that, and had a different etiology for the seizures. It would be quite unusual to be presenting so early with seizures due to biotinidase deficiency.
Actually, can I just ask you, how long would you carry on? Is this a lifelong treatment?
Yes. Yes, very, very important that treatment is continued lifelong, and when it is such a simple, cheap treatment, that is very, very clear. We have had, unfortunately, some patients for whom compliance has been a bit poor, and the intellectual outcome has been disappointing, even in siblings who were started on biotin antenatally by giving supplements to the mother. We don't think that, well, the intellectual outcome was disappointing, and we suspect that that was because of poor compliance.
And what would be the dosage that you would advise? Because you need to give pretty high doses.
Yes. So we give the same dose throughout life, essentially. So we give, 5 or 10 milligrams, occasionally 15 milligrams a day, regardless of your age, and it seems to work fine.
Okay. Thank you.
Actually, we did consider hollow carboxylase deficiency, but then our serum biotinidase levels were low, and the other metabolic panel did not show any. We went through reports which said differences amongst the metabolic substrates that are detected, but we had not detected any of them in the Thank you. Thank you.
Thank you, Padma. Last case by Dr. Venkateshwari.
Good morning, everybody. We have heard lots of theory on GLUT1 transporter deficiency, and especially after Dr. Ramesh's talk on GLUT1 deficiency, I think all of us are going to diagnose GLUT1 transporter deficiency frequently. So we have a child with suspected GLUT1 transporter deficiency whom we have started on ketogenic diet. We just wanted to share our thoughts. This baby actually, he presented to us in early infancy at around 3 months of age with an uneven full antenatal and neonatal period. The parents brought him with complaints of abnormal movements of the left hand for 3 days and some low-grade fever for 1 day. Initial admission, we noticed that the baby was hypotonic, he was not following light, he had social smile, there was not even partial head control, his HC was on the lower side, he had intermittent jerky movements of the left hand. We proceeded with the baseline investigations. The CRP was negative, his basic metabolic workup was normal, his CSF sugar was low, but he had mild pleocytosis with slightly raised protein. So we awaited the cultures, we treated him as like meningitis with IV antibiotics. We started him on phenobarbital. Neuroimaging was normal, EEG was normal, baseline screening for inborn errors of metabolism was normal. We actually discharged him after 1 week of IV antibiotic on phenobarbital, and we asked them to come for follow-up. At discharge, we noticed that those movements were still persisting. Within a week, the parents came back saying that the limb movements were still persisting, and they were actually worried the movements had actually increased in frequency and severity. And there was no history of fever or lethargy. The baby was otherwise feeding well. The neurologist reviewed the child, we stopped phenobarbital, and he thought like, are we dealing with something else? Let's repeat an EEG, let's do a video EEG now. The video EEG was abnormal. He said like, because the infective workup was normal, why don't we again redo a CSF and see what's happened to the CSF glucose, because recently he had seen a child with query GLUT1. So we repeated the CSF this time. This time the CSF glucose was still low, the blood sugars were normal, the cell count was nil, and the CSF lactate was on the low normal range. Unfortunately, in our country, we don't have labs which do molecular diagnosis for GLUT1 deficiency, and thinking of erythrocyte glucose uptake was beyond our reach. So we were wondering what to do next. Then we thought, shall we do a PET scan? So here we have an infant with low CSF sugars documented twice, the low CSF blood glucose less than 0.4, normal sugar with a normal CSF protein and cell count once, and a CSF lactate in the low normal range. We proceeded with the PET scan. The PET scan showed significantly reduced uptake in almost the entire cerebral hemisphere cerebellum, sparing the right frontal and the right putamen region. So we were still not sure, because with this PET report, the radiologist said like this could be GLUT1 deficiency. So here is an overview of the CSF. We repeated the CSF 2 months later after the PET scan, and the CSF still showed low sugars. The CSF sugar was 29 and the corresponding random blood sugar was 108, and the ratio was less than 0.4. So we did a net search and we found a research lab which where we contacted Dr. Joanne Pascal, who was actually interested in our patient, and he said like, why don't you mail me the PET films as well as the patient sample for DNA analysis. We are still awaiting his report. So pending the molecular analysis, we started this baby on ketogenic diet at 9 months of age. He's on ketogenic diet for the last 1 year, and he's on regular follow-up with the neurologist who's put him on ketogenic diet. There are no abnormal movements now, there are no seizures. He still has developmental delay, but he's been doing quite well. He's sitting with support, he's standing with support, his speech is still not good, he's babbling, he has Pincer grasp, and his hearing and vision is normal. So this is mainly to highlight that whenever, from a pediatrician's point of view, when you have a baby with persisting low CSF sugars, we should think of GLUT1 transporter deficiency, and there are research labs which are there to help us out in molecular diagnosis. Thank you.
Thank you. If there are no questions on that, I think we close this session. I thank Dr. Ramesh, you want to add something?
On the GLUT1 patient, if it's consistently abnormal, we don't have to argue with that, irrespective of what the laboratory is going to say. So we'll have to wait and see what that child does. But I need to ask a general question in this metabolic session, as someone who lives outside India, but I'm an Indian. So I want to know, we have heard about the laboratories offering you investigations. Do we have quality control of those? In other words, as clinicians, when you get a result, are you able to say that, yes, that is a genuine result and I can believe this? Do you have a consortium or a mechanism whereby the laboratories are inspected periodically so that there is, the clinician can rely on the result? Because the families are spending money to get these tests done. So they deserve a result which is reliable and which helps their clinical problem solving. So can I have a consensual answer how it happens?
I know of a quality control program that the Christian Medical College Vellore offers for about 12,000 laboratories in the country. And there is a commitment, a contractual commitment between those laboratories and CMC to have random samples sent 3 to 4 times in a year in order to have this recertified every year, along with surprise checks and cross checks. I know during the time that I was at Vellore, this was highly valued as an important landmark in maintaining standards, at least in some of the laboratories that are well known now in the country. But I must also say there are so many other laboratories which are not part of such a scheme, and I'm sure there must be other alternative plans under the quality control of the Government of India to have been able to perhaps bring these laboratories under certain quality control. But nevertheless, I admit this is a great deficiency in our country.
I would request Dr. Andrew Morris to do the honors. Could you please hand over the mementos to the chairpersons, Dr. Mohammed Thambi, Dr. Matthew. And Dr. Nandan. Indian Academy of Pediatrics. And his area of interest is infectious diseases. And Professor Velusamy did his undergraduation at Stanley Medical College, his MD at Madurai, and DM Neurology at the Madurai Medical College. He is presently Professor of Pediatric Neurology at the Stanley Medical College, and his area of interest is epilepsy and metabolic problems. There is a slight change in the the speakers of this session. We have recent neurological advances in tuberous sclerosis complex by Dr. Richard Appleton, followed by leukodystrophies Indian scenario.
Good morning. We'll start the first topic. It's a common neurocutaneous disorder. It's tuberous sclerosis. What is new in tuberous sclerosis by Richard Appleton. Over to Richard.
Thank you very much. It's my third and final offering at this amazing conference. Like my colleagues, I've learned an awful lot in the past day and a half, so thank you again. This will be quite a rapid run through, and just, if you like, touching on some advances that are currently in the process of being introduced within this condition. Just again, one of my favourite artists, Dali. I think he's an amazing mind, this painter, and in a way, a lot of what he painted and his thought processes, I think we as neurologists can actually take a leaf out of his book, to use that expression. The first thing I want to just mention is about the diagnosis. I mentioned yesterday that when you think about epilepsy, there are different levels of diagnosis. Is it epilepsy? Yes or no? What is the seizure type? What is the syndrome? And what is the cause? And always think, what is the cause? There must be a cause. Whether you find it or not is a different matter. If you don't think about it, you won't find it. I'm going to show you a video of a child aged 12 and a half, who around 12 months of age, 13 months of age, had 2 febrile seizures. They were prolonged, they were focal. She had no investigations undertaken. She had carbamazepine given for some reason. We don't usually do it in the UK for febrile seizures for 12 months. No further seizures, They withdrew carbamazepine. And then over the course of the next few years, she showed attentional difficulties at school and some behavior problems. And then she developed these episodes, you'll see. And one of my colleagues in general pediatrics had been seeing her with these episodes for about 6 months. And he thought they were psychogenic, non-epileptic seizures, which is my preferred term for pseudo-seizures. I don't like the term pseudo-seizures, because psychogenic non-epileptic seizures says what they are. They're psychologically induced non-epileptic seizures. So that was his interpretation of what you're going to see now. Not that. There should be a... The video was on. Thank you. There is some sound to this, but you may not hear it. You got the volume up?
The answer.
There's a TV on in the background. There's always a TV on in the background in UK.
Do you know where you are? Okay, do you know where you are? Oh, the answer.
So they're stereotyped, they're occurring in clusters, and very clearly these are epileptic spasms. They're not infantile spasms because she's 12 years of age, but they're epileptic spasms. So once we made that diagnosis, and someone actually examined her, she had about 5 or 6 depigmented macules. And she had a scan, and the scan showed the characteristic features of tuberous sclerosis. So it's fairly straightforward. But someone hadn't thought about the diagnosis, someone hadn't examined this girl previously, hadn't taken account of the attentional problems at school or the behavior difficulties, and hadn't done a full history and examination. Surgery for epilepsy and TS is now a realistic option and being increasingly performed all over the world. And there's different ways of approaching different surgical approaches. There's lesionectomy, and the first scan you see on the left was undertaken in a child who's got a marked area of frontal lobe dysplasia in the left frontal lobe. But unfortunately, the neurosurgeon was somewhat conservative in his approach, and only took out a small amount of the frontal lobe dysplasia, and the child was seizure-free for 24 hours, and then kept on seizing thereafter. The child also has a SAGA, which I'll discuss in a moment, as you can see, at a characteristic place, the foramen of Monroe. And that's a separate issue that may well demand surgery. The child on the right is one of my patients. If you look at the left temporal lobe, it's very dysplastic. You've lost the clear white-grey differentiation. And this child has got almost no cutaneous stigmata of tuberous sclerosis, was having frequent seizures, and we discussed with the family about temporal lobectomy. Even though we know the diagnosis is confirmed on genetic mutation, this child has got tuberous sclerosis. And we proceeded to actually take out, we being the neurosurgeon, and we took out the left temporal lobe, and that child's been seizure-free now for 15 months. Now, at some point, the child may well develop further seizures, but that period of time, the child has been seizure-free and has made some developmental progress. And he's only 3 years of age when this was actually undertaken. And the third approach is corpus callosotomy. That's obviously not a resective, curative procedure, it's a palliative procedure as a neurosurgical technique. But in children who are having frequent drop seizures, and you've all seen them many times a day, atonic or tonic seizures, the ones that cause physical injury, particularly to the head and the face, corpus callosotomy can result in a significant reduction in seizure frequency, even total resolution of these drop seizures. And just 3-4 weeks ago, the surgeon at Alder Hey again undertook corpus callosotomy, another one of our patients with tuberous sclerosis, and she has been seizure-free, drop seizures, ever since. And she is much more alert and more responsive, which again goes with not just a reduced seizure frequency, but the improved EEG findings in these patients. So the bottom line, in terms of tuberous sclerosis, is that surgery for the epilepsy in this condition is a real possibility. SAGA, you've all heard of these, otherwise known as subependymal giant cell astrocytomas. About 10 or 12% of patients with tuberous sclerosis will develop a SAGA. More common in males than in females, and more common to be seen to grow beyond 5 years of age. And as you saw in one of the initial MRI scans, it most commonly occurs around the foramen of Monro, which is a very important place eloquently within the brain, because it can cause obstruction to CSF flow and therefore hydrocephalus. And many of these will actually grow and become symptomatic, particularly demonstrating symptoms and signs of hydrocephalus. How you diagnose a SAGA? Well, it has to be intraventricular, growing, regardless of size, or identifying a stable lesion that's at least 0.5 or 1 centimeter in diameter. And there's some debate still within the tuberous sclerosis groups within the States and the UK and Europe as to whether the definition should be 0.5 centimeters or 1 centimeter. And the symptoms, in terms of hydrocephalus, as you all know, presenting due to a SAGA, positional headache, raised intracranial pressure, blurred vision, behavior changes, and rarely sudden death. I mean, that really shouldn't be happening in Europe or the States, but there have been reports of sudden death of undetected, undiagnosed acute hydrocephalus due to a SAGA in TS. What about monitoring with SAGA? Well, the natural history, as I said a moment ago, is that most tend to develop or grow after the age of 5 years, and the peak period of growth is between 5 and 18 years of age. But in fact, they may still grow beyond 25 years of age, so you can't totally relax at 25 years of age saying the SAGA you see will show no further growth. It might still grow. They particularly grow fast in young children and unlikely to rise de novo for the first time in young adults. So if they haven't been present before 25 years of age, they probably are not going to occur for the first time beyond that age. Now, the consensus in Washington from the tuberous sclerosis group earlier on this year in April came up with this recommendation or protocol for surveillance or interval scanning. If a child has no SAGA, then every 1 or 2 years, routine imaging should be undertaken up to 25 years of age. If it's a stable SAGA, and how you define stable depends upon how many previous scans you've had, of course, it's every year up until, at the moment, they haven't come up with a set endpoint, but probably by 25 years of age. If it's a growing SAGA, you should scan every 6 to 12 months, but earlier if the child develops clinical symptoms. So it's one of those situations where you'd probably scan before the child became overtly symptomatic. Now, up until recently in the UK, the consensus, well, it wasn't one. And we tended not to do routine scans every 6 months, 12 months, 2 years. That may change. And we tended to scan for any clinical indications, so any possibility of hydrocephalus, a change in behavior, lethargy, vomiting, headache, on positions in particular, we would scan. We wouldn't think about it, we wouldn't base it on examination, we'd actually just scan. But that's changing, and the reason why it's changing is because there's a new therapy possibly in treating SAGAs, and I'm coming on to that. Up until recently, the treatment for SAGA was basically surgical. And there's two approaches. One is that you can wait till the child's symptomatic and has hydrocephalus, which some would argue is too late, and the child might have actually experienced some deleterious and adverse effects before you operate. Or you can operate before the child becomes symptomatic. And that is certainly the American approach, which is why they do regular routine scans. And if the SAGA shows signs of increase in size or ventriculomegaly, increased ventricular size without symptoms of hydrocephalus, then they would operate. Of course, surgery, being on the brain, is potentially dangerous. And there's two approaches. There's transcallosal or transfrontal. And depending on the neurosurgeon, they may have different approaches as to which one they would follow. But theoretically, a child may die in a neurosurgical intervention, not from the actual surgery, but from the anesthetic itself. You may have complications following surgery. And more recently, a medical option has now become a realistic possibility. The problem with the medical treatment, medical approach, is that short term, all patients on this treatment will have adverse effects, 100%, guaranteed, no question about it. An uncertain feature is the long-term side effects of long-term treatment, and of course the cost. So I mentioned about the two approaches in terms of surgical, transcallosal, transfrontal. For instance, in King's College London, Great Ormond Street Hospital, they have two different approaches. One does a transcallosal, one does transfrontal. It depends, I guess, where you've been brought up and your prejudice and what you think is right for your experience. And the indications, as I said before, are SAGA with clinical hydrocephalus, SAGA with ventriculomegaly but with no symptoms of hydrocephalus, but imminent because ventricles are increasing in size, or enlarging SAGA, which is solitary and accessible. So it's getting bigger, there's no ventriculomegaly, but you know it's going to get bigger still, so why wait for symptoms? Operate. Medical. So when would you consider using medical treatment? Well, maybe if there's multiple SAGAs, like a little bunch of grapes, that are not accessible surgically, either transcallosally or transfrontally, or maybe following subtotal surgical removal, or maybe if there's a collection of them, you can use medical treatment first to shrink them. I'll explain why in a minute. And once you've shrunk them and they're more accessible and the neurosurgeon feels safer and happier, more comfortable, then to proceed to removal. And obviously, in any situation like yesterday, we've got to stress, it's a multi-team, multi-specialist, multidisciplinary discussion. So in our hospital in Alder Hey, we have two big teams, a neuro-oncology team, which deals with brain tumours, and we have an epilepsy surgery team. And occasionally, these sort of patients are discussed in both MDTs, which is really, really taking clinical governance to the utmost, optimizing discussion in two highly specialized groups, and obviously involving the child and the family in the discussions and in the decision that we think is appropriate, and depending on what the child and family want to do. This is just a cartoon. I'm going to focus a bit more on the medication approach now, which is sirolimus or everolimus. These are the two mutations, and the mutations basically allow mTOR, which is a mammalian target of rapamycin, to express itself and to produce proteins and to produce tumors and to produce increased cell division and blood cell expansion. When TS1 and TS2 are present in tuberous sclerosis, mTOR runs amok. It produces these tumors. So the medication has been developed to inhibit the mTOR. And by inhibiting the mTOR, you will prevent growth of cells and cell division, and ultimately tumor development. And the tumours you can get in tuberous sclerosis, as you know, are seizures, but also AML in the kidney and LAM in the lungs, although mostly only in women and really in adult life. The key one to think about in children is a SEGA. So everolimus is a derivative of sirolimus, which is another word for rapamycin. And that's derived from an antibiotic from the bacterium Streptomyces. Now, in 2011, the European Medicines Agency, which is a fairly important European regulatory body, a bit like the FDA in the States, produced this comment about everolimus, indicated for the treatment of patients aged 3 years and older who suffer from SEGA associated with TSC and require therapeutic intervention, but who are not amenable to surgery. So it's a fairly loose endorsement of you can think about using this medication in that specific situation. And some of the evidence leading to that, I'll just give you now. And this is from Darcy Kruger from the States, and this was an initial small study, 28 patients. 15 underwent genotyping, 14 positive with a mutation, and they received everolimus therapy over 6 months. At the end of 6 months, at least 30% reduction in size in 75% of patients, at least 50% reduction in size in 9. That's a shrinkage of 50% of these SEGAs. That's quite significant. There were no new lesions developed, no worsening of hydrocephalus, and 16 underwent 24-hour video telemetry at 6 months. And they found the seizure frequency reduced in 9, was unchanged in 6, and increased in 1. And I just mention that because you'll see why in just a moment. But the seizure frequency was not even a secondary outcome. It was an observational bit to the study. They also did repeat neuropsychological assessments in 24, and there was no change. But to be honest, a 6-month assessment between pre and the post-treatment, to me, doesn't seem a useful or realistic time to reassess these children. The quality of life childhood epilepsy outcome scale improved. All had adverse events, 4 serious. This is 100% I mentioned, because on this medication, you will get stomatitis, mouth ulceration, mucositis, sinusitis, and there were some cases of pneumonia and also tooth infections. Now, because of that initial pilot type study, a much larger study was undertaken, and it was prospective and gold standard randomized controlled trial. Everolimus against placebo in a 2-to-1, so twice the number of patients received everolimus compared to those receiving placebo. And the primary outcome was based on neuroimaging, and all neuroimaging scans were sent to a central analysis center in the United States. And the SEGA response was defined as a reduction in target SEGA volume, the sum of the volumes of the target SEGA lesions, of at least or greater than 50% relative to baseline, plus non-worsening of non-target SEGAs and no new SEGAs over 1 centimeter in diameter, which is the defining criteria for SEGA. 117 patients, so a much more substantive study than the Kruger one of 28. And 78 received everolimus, 39 placebo, 2-to-1. And the response, 35% reduction in SEGA volume compared to 0% in the placebo group. Fairly dramatic. And no deaths, which is very encouraging. But if you look at the safety profile in at least 10% of patients, then everolimus, and the red arrow demonstrates, a significant number had stomatitis and mouth ulceration compared to placebo group. But there was amenorrhea, and that does appear to be emerging as another adverse event that wasn't picked up initially. It wasn't picked up in the initial pilot study, but certainly was in this study, and also from anecdotal use of everolimus subsequently. And another important concern is that when you discontinue, and if you discontinue everolimus, not only does the SEGA increase in size, but there may well be a rebound, a dramatic increase in the rate of growth initially, before it may then settle down. And that's worrying, because it tells you this really has to be a lifelong treatment. So my experience is limited to one, and this actually is with sirolimus, not with everolimus. So this is the girl you saw in the video. Because when we scanned her kidneys, she had multiple AMLs in her kidneys as well. And one was considered possibly treatable with embolization, but in the end was not. And the family were keen to pursue sirolimus to treat the AML in the kidney. But she also has a SAGA. So I'll just show you some sequence of MRIs. So this is the MRI pre-treatment with sirolimus for her kidney AML. And you can see with the arrow where it's situated, typical place. That was February 2011. Then we started sirolimus. And 6 months later, it shrunk. And August this year, it's much smaller indeed. And the ventricular size has gone down on the right as well. What about the renal AML, you ask? Well, the renal AML have shown no increase in size, but they haven't shrunk. So the nephrologists are quite happy to continue treating this girl with sirolimus, and I'm happy to treat her in terms of the SAGA point of view as well. And she did develop mouth ulceration for the first 3 or 4 months, but that has resolved now, and she's currently, as far as we're aware, has no unwanted side effects. What about moving on to the concept of using this medication in epilepsy? I mentioned in the Kruger study, they found as an observational interesting phenomenon that some of the patients with seizures showed a reduction in seizure frequency. So the manufacturers of everolimus, Novartis, thought, well, maybe it can be treatable to use to treat seizures and everything else in TS, including skin lesions. But this is epilepsy. Some preclinical studies and rodent models have suggested that actually it might be effective in reducing some of the seizures. And France, again, he's very well known in the tuberous sclerosis world, added rapamycin, sirolimus, to antiepileptic treatment in 14 patients with completely refractory focal epilepsy, including having had VNS inserted and the diet. 3 patients, it's only 3, 90% reduction in seizure frequency, 7 patients showed a 50% reduction, and 4 patients showed no response. Longer term, after 3 to 6 months, 3 patients lost efficacy, 2 patients had sustained improvement and remain on treatment, and 2 patients had sustained improvement and have come off rapamycin. What we don't know is longer term, after 12 months or 2 years. Okay? There's 14 patients. So because of that, we now have this study which may well be taking place imminently in the States and in Europe. Everolimus as adjunctive treatment for refractory focal seizures in TSC, the so-called EXIST-3 trial, which EXIST-3 stands for Examination of Everolimus in Tuberous Sclerosis. And the protocol says any age over 2 years, both sexes, focal onset seizures, minimum of 8 seizures in the preceding 4 weeks, receiving at least 1 up to 3 anticonvulsants, a fairly drug-resistant or refractory population, double-blind, placebo-controlled RCT, and they want to recruit 225 patients. So 4-week baseline, a 12-week double-blind period, only 12 weeks. However, this study has been developed and designed on very limited scientific evidence to support the drug's anticonvulsant or anti-epileptic properties. One was an observational measure from another study, and the second was this one of intractable epilepsy patients, of just 21 patients. It's a very, very strict protocol. Guaranteed short-term side effects, as I've said. Long-term side effects we're uncertain. And expensive. The middle dose, based on a middle sort of age and a middle surface area, is £25,000 per patient per year. I think I have some concerns with this protocol, but I have a feeling it will actually take place, particularly within the States, because the families who are members of the Tuberous Sclerosis Association, the TSA, are very keen to do anything possible to help their child's epilepsy and their quality of life, understandably. But one has to bear in mind the concerns I raised in red here. And the final thing I want to discuss, which is prevention better than cure. And this is really quite hot off the press information. And again, from Joswiak, who's done an awful lot, again, within this field of tuberous sclerosis, and he was the main author for the randomized control study in EXIST-1, which was the SEIGA, everolimus versus placebo study. And this is 45 patients with prenatal or perinatal diagnosis of tuberous sclerosis, confirmed postnatally with mutational analysis, put into two groups. Standard group and preventative group. The standard group received an anticonvulsant antibiotic drug after clinical seizures started. The other group, the medication was started only when active discharge is seen in an EEG, but before seizures occurred. So they're treating the EEG and not treating the child. 2-year follow-up in the preventative group, this is what they found. The term mental retardation we don't use in the UK, but this is what they have used, so I put it in single quotation marks. They said it was less common and severe in the preventative group. Again, in the preventative group, more patients were seizure-free, low incidence of drug-resistant epilepsy, and low number of recurring polytherapy in those who received anti-epileptic medications before seizures developed. It's an interesting observation, and at this point I think that's all I would actually describe it as. It's not really instinctively, intuitively what we would do to use medication or medications to treat an EEG before seizures develop. And I think we need much more data on that particular aspect. So to conclude, not all epilepsy in children with tuberous sclerosis presents as infantile spasms. The patient I showed you on video is the case to illustrate that important point. Again, it comes down to history, an examination, and think about what is causing this child's epilepsy. The second, which I think is equally acceptable and is taken for granted now, is SEIGAs don't cause epilepsy, but they do cause hydrocephalus. And if untreated, it can lead to developmental problems, to learning difficulties, loss of potential at school, and even sudden death. There is now an alternative to surgical treatment of SEIGAs, but it is expensive. It will cause acute short-term side effects and has to be lifelong once started when treating SEIGAs. It remains unclear, as far as I'm concerned, whether this medication, everolimus, might be effective as an anticonvulsant. I really have some concerns about that. And finally, the role of medication to prevent seizures and epilepsy developing in the first place is an interesting concept, interesting optimistic hypothesis. That's all you can describe it as at the moment. We just do not know. And in a way, I wish I had this sort of wisdom. It might help me to answer some of these questions and the questions posed to me by some of my families in this difficult situation. Thank you.
Thank you, Dr. Appleton. We will reserve the questions at the end of the session. May I now call upon the next speaker, Dr. Sunita Bijarnia Mahai. I hope I have pronounced it correctly. She is currently working in Sir Gangaram Hospital, and she has had her fellowship in Genetic Metabolic Disorder Service in Sydney, Children's Hospital Westmead, Australia. And she is now a consultant genetic metabolic physician at Sir Gangaram Hospital, working with Professor I.C. Verma, and she has had a large experience and published many papers with the illustrious Professor Verma, the center where we refer most of our cases for investigations. Dr. Sunita.
Thank you, sir, for the very kind words. And at the outset, I would like to thank the organizers for inviting me for such a wonderful meeting. I'm really honored to be here as a representative of Dr. I.C. Verma, who couldn't be here for some reason. So I hope I will be able to get his message through this talk. So my talk is on leukodystrophies with an Indian scenario. Well, when we think about leukodystrophies, we first think about what it is. So basically, they are disorders that affect the growth or maintenance of the white matter, which is the myelin. There are many definitions and there are many classifications. People tend to include many disorders into the same umbrella. So one such foundation is the United Leukodystrophy Foundation, under which there are about 40 types of disorders that are described, which may not necessarily be leukodystrophies, but they have something to do with the myelin. Classically, these are the 5-6 disorders like adrenoleukodystrophy, metachromatic leukodystrophy, Krabbe disease, Pelizaeus-Merzbacher, Canavan, and Alexander. But in the ULF, they have also included other disorders like chromosomal, infections, vascular, and other metabolic disorders. So the term leukodystrophy was first coined by two doctors, Bilchowski and Henneberg, which, like everybody would know, it's white, and dystrophy, which is ill growth in Greek. What we tend to follow in our practice is a classification given by Powers in 2004, and there are 4 essential features for a leukodystrophy. The first being that there has to be it has to be genetically determined. So there has to be a genetic cause. Second is that it has to be a progressive, it should show a progressive clinical course. Third is that it predominantly and confluent involvement of the cerebral white matter. And the fourth, these 3 are pretty simple, but the fourth one is little, because it is the primary lesion of the myelin and myelinating cells. So not as part of a multi-system thing, but the primary lesion should be in the myelin. So that's how one can narrow down to fewer disorders. So with this definition, one would be able to exclude conditions like multiple sclerosis, infections, and nutritional like vitamin B12 deficiency, toxic, and other causes if we were to follow this stringent classification. So our experience at Sir Gangaram Hospital over the last so many years is we've had the experience of testing and diagnosing all these disorders. I have included more than the classical ones just for the, this thing. Oh, I'm sorry. Is this the marker? Okay. So I've added cystic megalencephaly because this is the most common leukoencephalopathy that we see, although it is not one of the classical leukodystrophies. We've seen about 105 cases. And then the second one is Krabbe disease, followed by metachromatic leukodystrophies. We've also seen many cases of X-linked adrenoleukodystrophies, and the others which usually do not classify under leukodystrophies, like the GM1 and the GM2, Gaucher and Niemann-Pick. Apart from that, among the other leukodystrophies, we've seen only a few, and these I have mentioned because they have been molecularly, genetically proven. So let's start with the disorders one by one. Since MLC is the most common leukoencephalopathy that we see in our practice in India, this is the first. So this basically, essentially it means megalencephaly is like large head. So that is present in all these children. Developmental delay in almost all, with gait problems, seizures. Seizures are present in large majority, but they are like an incidental finding. Then speech delay and neuroregression in a few patients. So the clinical features is also very varied because the onset can be right from birth till about adulthood. And usually in our pediatric practice, we see them as young as 8 to 12 months old when they purely come to medical attention because of the large head. Sometimes they have seizures which precipitate, and then few of them, just to mention, Dr. Verma specifically asked me to say that these are, there are even professionals walking around who have MLC. So there's a very wide variation in the clinical phenotype in MLC. And the other neurological findings are spastic ataxia, there's some incoordination, dysarthria, but no dysmorphism. The neurophysiological studies are normal, except the EEG, which may be abnormal in these children. In the neuroimaging, I'm sure the next talk will cover this, but in particular MLC, there is a global dysmyelination right from the central semi-ovale to the subcortical U fibers. And then there is gyral widening and with cyst formation. Now these are the particular cysts that form in very classically in the temporal lobe, but also in the frontal lobe and occipital regions. There are extensive white matter changes with relative sparing of the deeper structures, like the limbs of the internal capsule and the corpus callosum. The patients with more extensive changes are usually more severely affected. So the story of MLC started with Professor Singhal, who presented an abstract in the 8th Asian Ocean Congress of Neurology in Tokyo in 1991. After that, Dr. Udani made an abstract in 1994, but it was really identified in the world outside after Dr. Wandernap's description in 1995 in a paper where she published leukoencephalopathy with swelling and discrepantly mild clinical course. So that's why this disorder is also known as Wandernap's disease. Now, genetically, the gene was first localized by Topko et al. In 2000, followed by the identification of the gene, which is now called MLC1 by Leaguewater. Now, since then, there is another gene that has been identified, which causes the same disorder, megalencephalic leukodystrophy. This was by Lopez Hernandez, very recently. So the gene MLC1 has 12 exons, and it encodes for a membrane protein, and it has 8 predicted transmembrane domains. The MLC1 is mainly located within the CNS in the astrocytes and the astrocyte junctions adjacent to the blood-brain and CSF-brain barrier. So role is, in astrocyte, this protein has a role in astrocyte osmohomeostasis. So this was described by, it is still, the pathogenesis is still largely unknown, but it is still being investigated. So the latest investigation has come up with this finding that there is a defects in the intracellular calcium dynamics, and this protein also takes part in the sodium-potassium ATPase associated molecular complex, and thus functionally it interacts with calcium-permeable channels. So essentially, if there is a mutation in the gene, the protein is defective, and this process gets haywire, and thus leads to brain swelling and fluid cysts and myelin vacuolations. So this is just a picture of the gene with the different mutations scattered all over the gene. But the interesting part for us is that there is one common gene in all the Agarwal patients. So Agarwal, as everybody knows, is a very prominent community in India, originating from North India. I'll tell you about this a little bit. There is only one publication from India, that is from All India Institute. They identified this mutation this is the most common Agarwal mutation. Apart from that, there are 2 or 3 more mutations. 2 of them were actually novel. They have not been described earlier. In our experience, which we have not published yet, but about the 105 cases, most of them were Agarwals. Most of them had homozygous Agarwal mutation. Amongst the non-Agarwals, they were varied. So this is our experience with MLC. Now, Agarwal community actually excites us because being in genetics, this has given us a very important information that this particular gene has a mutation which may have may have started from its founder. So a little bit about the founder of Agarwal's. It occurs predominantly the disorder occurs in Agarwal community. They have origins in North India from the state of Haryana, from the legendary King Maharaja Agrasen, who lived in Agroha about 5,000 years ago. So his descendants are, of course, spread all over the world because of their astute business acumen, and but they still remain a little closed community. So we can identify with them in the genetic. So apart from MLC, we have been able to find few more founder mutations in the Agarwals. For example, in calpainopathies and hereditary fructose intolerance and so forth. So these are the genes, MLC1 being the most prominent, being responsible worldwide, being responsible for 75% of cases of MLC. Other than that, there is this hepacam gene, which actually has two patterns of inheritance. It can actually manifest either recessively or even dominantly. So after the MLC, we move on to metachromatic leukodystrophies. This is the second most common leukodystrophy in India. This was just one series that I thought I would like to share with you. It came out from Bangalore by Bindu Mahadevan and Tally et al. They published their clinical series of 40 patients with MLD, and very interesting observation of 25 of these 40 cases were actually from consanguineous marriages. So 62.5% was the consanguinity rate. Family history was present in four cases. And they only found two types. Classically, there are three types of MLD, but in this series, they found majority, 90% of them were late infantile, whereas 10% were juvenile. The juvenile group mainly presented with behavioral problems, but there were also progressive ataxia and dysarthria. So I'll just come to the cases now, just to illustrate. This was one of our cases that the family came to us for a prenatal diagnosis in our clinic. And they brought along their previous child who had been immobilized by that time. Like he was 5 years old when he came. So upon taking the history, the child had been all right till 1 year of age, after which there was a regression in his motor milestone. So at 3.5 years of age, he had lost independent walking. And at 3 years, 9 months, he also threw a generalized tonic-clonic convulsion. After which, all his movements were totally gone. So he was completely bedridden when he came to us. So there was a rapid decline, and his speech also regressed. On examination, there was a very variable tone with peripheral hypertonia, truncal hypotonia. His head circumference was normal. So we performed an MRI. So these are the MRI findings. It showed a white matter hyperintensity in the T2 and also in the TRIM, which were periventricular, also involving the corpus callosum, and with a very tigroid sort of appearance. There are small dots which are hypo-intense, which shows some changes in the white matter. So we suspected metachromatic leukodystrophy in this child based on the clinical and the MRI findings. And the enzyme assay was low in this case, but this was not good enough for a prenatal diagnosis. So we embarked on the gene study, and we found 2 mutations in this patient. Based on these mutations, we could then perform a prenatal diagnosis in this family. So thus far, we have done a few more cases of molecular analysis for the MLD. The ARSA gene is involved. There is only one more publication, again from All India Institute. And together, there are about 12 mutations. And other than the pseudo-deficiency allele, which was also present in 5 patients. So amongst all the mutations, only this one is a common mutation all over the world. So this is just giving you a little picture of how the mutation affects the modeling of the protein. So this particular mutation, where the tyrosine is replaced by serine, this is a normal structure of the protein, where the tyrosine is hydrogen bonded with threonine at position 57 and arginine at 308. Now, subsequent to the change of this amino acid from tyrosine to serine, this particular bonding doesn't take place. And thus, the protein that is formed becomes ineffective. It's non-functional. So this is how disease comes. Now, presenting our second case, this again the couple had come for a prenatal diagnosis, and they brought along their 5-year-old boy who had a history of, who had coarse faces. These are the facial features: depressed nasal bridge, short neck, low posterior hairline, medial flaring, gum hypertrophy, and he also had ichthyosis. And there was a history of developmental delay followed by regression, and by the time he had come, he was not walking. So